Hello, I'm Taha. I'm a fourth year medical student, and in this video I'm going to go over stable angina. So the contents of this video are, I'm going to run through what the causes of angina are. We're going to look at the pathophysiology, a little bit about the clinical symptoms, the investigations, as well as the management for stable angina. Let's jump straight in. So what actually is stable angina? So angina itself is characterized as chest pain, right? Chest pain due to a reduction in the blood flow to the cells of the heart. Alright. So let's have a look at what's actually causing the reduction in the blood flow. Let's imagine we have a patient, right? And he comes in with the characteristic chest pain of angina. The process by which angina actually occurs is known as atherosclerosis, right? Atherosclerosis is where there is a deposition of two primary materials, one being cholesterol and the second being inflammatory cells, right? And these deposit within the coronary arteries of the heart itself. So the walls within the coronary arteries get blocked over time, and this is a chronic process which leads to a reduction and a narrowing within the lumen. So let's imagine we have a coronary artery, right? So under normal conditions, blood would flow through the coronary artery, carrying along with it oxygen and perfuse the cells, right? Now, atherosclerosis, as we mentioned, is a deposition of plaques that is scattered within the coronary arteries. And when these plaques build up over time, they reduce the amount of blood that can actually flow through these arteries and reach the cells. So let's have a look at why this reduction in blood flow actually causes the characteristic chest pain that we see in angina. So, as we've mentioned, blood that flows through the coronary arteries carry along with it oxygen, right? Now, oxygen is required for aerobic respiration to produce ATP, right? Now, as you can imagine, the heart is working 24/7, right? So it is one of the organs in the body that has the highest oxygen demands, right? So it does not respond well to conditions where oxygen is not present. So when there is narrowing of the lumen within the coronary arteries, there is also a reduction in the amount of oxygen that leads to the cells. This is a process known as ischemia. So what happens is that the cells within the heart recognize this reduction in oxygen, and they will release certain enzymes which will then stimulate nerve endings. This causes the characteristic chest pain that we see in angina, right? Okay, so it's important to mention here that angina can be split into two different types. So the first type, and the one we're looking at today, is known as stable angina. So stable angina is characterized by the chest pain that comes on only on exertion. So exertion meaning times of increased activity such as exercise. As you can imagine, when a patient is exercising, there is an increase in the oxygen demand, right? Especially to the myocardium of the heart. So when this demand is not met, this causes the characteristic chest pain that we see in angina. So the second thing that characterizes stable angina is that it is relieved by GTN, right? Glyceride trinitrate. GTN comes in two forms. It can be either as a spray or as a tablet. So what actually is GTN spray? To understand how GTN spray and GTN tablets actually work, let's go back to the pathophysiology of what angina actually is. So we mentioned that the pathophysiology is where there is a narrowing of the coronary arteries, which leads to a reduction in blood flow, ultimately leading to ischemia, right? What GTN does is it is a potent vasodilator, vasodilator. Okay, so what this means is that it will ultimately increase the diameter of the coronary arteries, right, which will allow better blood flow to the cells of the heart, especially under times of increased activity. The second type is known as unstable angina, and this is actually known as a acute coronary syndrome. This is something that we'll look at in another video, but just for the understanding of stable and unstable angina, unstable angina is characterized by chest pain even at rest. Alright, so let's have a look at the clinical presentation of stable angina. So we have a patient here. That comes in with symptoms of angina. So what would that look like? As we've mentioned before, it is of course the classical chest pain. Now this chest pain can be either a tightening sensation, or it can be described as a crushing sensation. The patient will use these words. So the next thing that we need to look out for is that chest pain can actually radiate. So the patient may complain of the pain radiating to either the neck, the jaw, it can radiate to the arms, and even the shoulders. And one final thing is that patients may also complain of shortness of breath, especially if the chest pain comes on at times of exertion such as exercise. Alright, so now let's have a look at the investigations that we can perform for stable angina. So the gold standard investigations for stable angina is known as a CT coronary angiography, right? Otherwise known as a CTCA. So let's have a look at what this is, how it works, and why we use it. So when the patient is undergoing a CTCA, what will happen is the patient will be injected with a iodine-based contrast that will be injected into their veins, right? Now, let's look at the anatomy of the heart for a second. When we inject this dye into their veins, what will happen is that the contrast agent will, let's imagine this is the heart, right? So the contrast agent will follow up through the inferior vena cava to the superior vena cava and enter the right atrium of the heart. From the right atrium, it will enter the right ventricle, okay? From the right ventricle, it will then go out to the lungs within the patient. And then after the lungs, it will be brought back to the heart into the left atrium, followed by the left ventricle, and then through to the aorta. Now, one important thing to mention here is that the coronary arteries all branch off of the aorta. So when the contrast agent finally reaches the aorta, it will then perfuse the coronary arteries of the heart. Now, there are a couple main reasons as to why we perform a CTCA. The first reason being we can visualize which coronary artery is actually stenosed, right? We obviously have the bunch of different coronary arteries such as the left, the LAD, and the right coronary arteries. So this will allow us to visualize which coronary artery is actually the problem. The second thing it allows us to do is by how much, right? How much is the coronary artery actually stenosed? It could be stenosed just by 40%, it could be 50%, or it could even be 70%, right? And the third thing the CTCA will allow us to achieve is that we will be able to differentiate between the substances of the plaque itself. Either the plaque will be calcified, or it will be uncalcified. So the distinction between the two is that a calcified plaque is relatively stable compared to the uncalcified. And what this means is that an uncalcified plaque will have a tendency to rupture spontaneously, meaning that a patient could be at higher risk. All these three will allow us to tailor the management plan to the patient themselves. This will allow us to understand how aggressively we need to treat the patient and even look and consider surgical options. The second thing to understand is that if a CTCA is unsuitable for a patient, so let's have a look at what that actually means. If the CTCA is unsuitable, the types of patients that it is unsuitable for could be patients who are just allergic to the iodine-based contrast that is needed for the CTCA. It could be the fact that the patient has severe renal impairment and the iodine within the contrast could worsen that impairment, or it could be the fact that the patient has rhythm issues of the heart, such as tachycardias, which will make it very difficult to get smooth images of the coronary arteries themselves. So when this actually occurs, there are a couple of different imaging techniques that we can use. They are known as non-invasive imaging techniques. So these include things such as stress echocardiography, myocardial perfusion scintigraphy, and finally we can also look at cardiac MRIs. Alright, so now let's have a look at the management options for stable angina. So we have a patient here. What are the different treatment options that we can offer for angina? So the very first thing we'll look at is lifestyle interventions. The second thing would be medical management. And then the third thing we'll look at is surgical interventions. Alright, so let's have a look at lifestyle interventions that we can offer towards every single patient with a new diagnosis of stable angina. So we can look towards reducing the patient's alcohol. So we can look towards reducing the patient's alcohol intake. We can also increase the level of exercise that they may be currently performing. We can also have a look at changing their dietary habits. We can look at options for smoking cessation, and ultimately trying to also optimize their BMI and their overall cardiac health. So the second thing we can look at is medical management. Alright, so medical management is also split up into three. We have immediate symptomatic relief, we have long-term symptomatic relief, and we also have secondary prevention of angina. So let's have a look at the immediate symptomatic relief that we can offer patients. So we have a patient who is experiencing chest pain. What are the sort of things that we can offer? So patients will be given GTN, right, glycerol nitrate. We mentioned this point earlier. GTN can be given as a spray or as a tablet. and both of these are taken sublingually. The next thing we'll have a look at is long-term symptomatic relief, right? So the two main drugs that we can use here are beta blockers, such as bisoprolol, and calcium channel blockers, such as amlodipine, right? We can use these as monotherapy, or we can combine them to give dual therapy, okay? In the event that these drugs, so the beta blockers and the calcium channel blockers, don't actually relieve the patient's long-term symptoms, a specialist cardiologist can then look towards adding in second-line drugs, right? And these drugs include things such as long-acting nitrates. So we mentioned GTN before. That GTN is a short-term vasodilator. We can look towards long-term nitrates such as isosorbide mononitrate. We can look towards drugs such as ranolazine, nicorandil. Alright, so the final thing we can look at is secondary prevention, right? This one is fairly simple to remember. It is just the 3 A's, okay? So the 3 A's being aspirin, atorvastatin, and an ACE inhibitor. So the final thing we can look at is surgical interventions. The type of patients that surgical interventions are preserved for are patients whose symptoms cannot be controlled through medical management, or they have severe disease progression. So there are two main types of surgical interventions that we can look towards. The first being percutaneous coronary intervention, and the second being coronary artery bypass graft, so PCI and CABG. So in PCI, the surgeons will either go through the patient's brachial artery or the femoral artery. Under X-ray guidance, the catheter will be guided through the arterial system until it reaches the coronary arteries, by which point a contrast will be injected into the coronary arteries, which will allow us to visualize which arteries are actually stenosed. Once we have a better visualization of which arteries are stenosed, so let's imagine here is the artery that is stenosed, we can bring the catheter into the coronary artery, and with the balloon that is attached to the catheter, it can be inflated to push on the plaques within that artery. Once the plaques are pushed, a stent can be put into place by the surgeons to allow for adequate blood flow to return to the heart. That is PCI. To have a look at what the bypass graft is, let's imagine a coronary artery within the heart and there is severe stenosis. So a bypass is usually reserved for patients who have severe stenosis within the artery. So what the surgeons can do is take an alternative vessel and quite literally bypass the obstruction and the narrowing within that artery to allow for blood flow to go up and around and return to normal. Now there are a couple different vessels that can be used as this graft. The first one being the great saphenous vein, and this is taken from the inner thigh. The second being the internal thoracic artery, which is also known as the internal mammary artery, and the last one being the radial artery. Thank you so much for watching this video. I hope you enjoyed it. We've got notes on this topic as well as thousands of others and a huge Notion template, so link to that will be in the description. Thank you.